And let me know when it says meeting started.
So it says recording and transcription started automatically. Yeah.
Great.
So I think it started.
Cool.
And it says live.
Great. Okay, I'll just give it a few more seconds. Okay, hopefully that's most people in. Let me just bring up my little spiel. So hopefully everyone can hear and see me. I can see Max is still there. Max, can you hear me okay still?
I can, yes.
Great, cool. All right, so good evening, everyone, and welcome to tonight's primary care seminar hosted by the Primary Care Education Department at City St George's, University of London. My name's Lucy Williams. I'm a GP and clinical lecturer at City St George's. I'm joined by members of our primary care team, Professor Judith Ibsen and Vanessa, as well as some of our student partners, Rachel and Zara, who have helped support in developing and delivering this. So this seminar is the fifth and final of this year's primary care seminar series, which is in its third year, and it aims to showcase the diverse opportunities available within a career in primary care to both students and professionals alike. The seminars have been co-created with our medical students and students from other allied healthcare courses who have been the driving force behind these events. Tonight's seminar focuses on an important topic for both students and considering careers in primary care, as well as those already working in the sector. So I'm delighted to welcome tonight's speaker, Dr Max Kelen, who will be talking us through his work supporting trans health in the community. Dr Kelen is a GP working in South East London. His passions are women's health and trans health, and this has led him to his work in developing key services in the area. He's the GP lead at the Bridge Clinic, which is an innovative GP hub clinic providing both routine primary care and gender affirming care to trans and non-binary people. So Dr Kelen will speak on this for about the next 40 minutes or so, followed by Q&A. So please use the Q&A box to submit any comments and questions. So without further ado, I'll hand over to Max. So please go ahead, share your slides, Max. I can see them perfectly.
You can see the slides?
Yes.
All good. Thank you very much. Thank you for the intro. I was just saying to Lucy and Judith before we started that I've had quite a stressful day. I managed to have a minor car crash just a few hours ago. So I hope this seminar will be nice and relaxing for my nervous system. But thank you for having me. Yeah, so my name's Max Kelen, and I'm a GP, but I have two main special interests, which I've managed to kind of create these extended roles in. So one's in women's health and one's in trans health. So I split my time between being a salaried GP in Lambeth at Hetherington Group Practice, and doing the Lambeth Women and Girls Health Hub, which is a talk for a whole other day. But basically doing women's health, and also working for Bridge Clinic, which Lucy just started to describe. So it's a new type of clinic. It's a primary care led clinic, and we provide gender affirming care to trans and non-binary people in Southwark and now also in Lambeth in our new clinic, and also routine primary care in a trans inclusive environment. So I'm going to talk to you about my work mostly regarding that. Has this slide moved on? Oh, there we go. So yeah, the plan for today is I'm just going to take you through a little bit of terminology and introduction to gender affirming care. I'm then going to sort of make a case to you why I think trans healthcare and primary care is so needed, and obviously tell you about Bridge Clinic, because I tell everyone who crosses my path as much as I can about Bridge Clinic. I've never done a talk to an audience like you before, but I've been told that you'd be very interested in me discussing myself and my career path. So I'm going to do that, and kind of tell you how I've developed my special interest, because this is my 6th year post CCT as a GP. So I'm still relatively young. And then I'm going to talk to you about how we set up Bridge, and obviously have lots of time for questions and answers at the end. So ground rules. I hate the fact that I have to do this, but obviously trans healthcare is sometimes a politically charged topic. And this is a really safe space to ask all the questions you want. There's nothing wrong with not knowing something. And I think curiosity is a really great thing. Obviously, please don't be disrespectful. And, the point of this talk is not to have any kind of debate on whether trans people exist or whether they have a right to healthcare. They do. This talk is more to kind of inspire healthcare workers who are motivated to do better for their patients. And, trans people are some of the most marginalized and vulnerable members of society. So I'm sure people are quite familiar with the terminology, but just in case, while often used interchangeably, sex refers to the biological characteristics. So that could be like chromosomes, hormones, reproductive organs. It's actually a very woolly term. While gender encompasses the socially constructed roles, behaviors, and identities of a person. So if your sex and your gender match or are congruous, so your gender is congruous with the body or sex you're assigned at birth, you're termed cisgender. Transgender is the opposite of that. So anyone whose gender is incongruous with the sex they were assigned at birth, we call transgender or trans as an umbrella term. People get very worried about pronouns, and they may or may not be important to people. It's certainly dysphoric to be misgendered. My rule is always, if you're in doubt, use they, them. And you actually rarely need to use anyone's pronouns to their face, mostly when you're talking in the first person or the second person. When you're not talking about someone, you don't actually need to use someone's pronouns. So it's hard to get it wrong. So what is gender affirming care? So gender affirming care can encompass lots of things, but the most the most important medical intervention sought by trans people is gender affirming hormone therapy. And what gender affirming hormone therapy allows is the acquisition of secondary sex characteristics that are more in line with someone's gender identity. So that might be breast development, fat and muscle distribution that's congruous with the gender you're aiming for, more or less facial or body hair, and changes in the pitch of voice. Um, the reason we give gender affirming hormone therapy is to relieve gender dysphoria. And gender dysphoria is the potentially immense distress that some but not all trans people will experience as a result of the incongruence between their gender and assigned sex at birth. And that dysphoria could be physical, to do with body parts or how their body looks, or how they're kind of perceived socially within the world as well. Um, Another thing to sort of be aware of is that it's not as simple as male to female and female to male in a very sort of binary way. We talk about sort of masculinizing and feminizing pathways, because some people don't want to have a full transition. They might want to appear more androgynous or have a sort of non-binary identity. So yeah, rather than we just talk about masculinizing and feminizing. Some patients, but certainly not all, will want gender affirming surgeries. So commonly that's top surgery for chest, bottom surgery for genitals, and sometimes facial feminization or masculinization procedures as well. People might also seek hair removal, voice training, and of course, counseling and psychotherapy to guide them through what can be quite a difficult process. Um, I'm not going to go into the ins and outs of gender affirming hormone therapy, but I did just want to point out that it's not actually as complicated as you might think. When I started out doing this work, I assumed that it must be some really complex cocktail of drugs that you'd need to change gender, but it's actually really similar, really simple. So if you want to feminize, you give estrogen, and you titrate it to a level of sort of 400 to 600 picomoles per liter, and that's the same level as a cisgender woman. If you want to masculinize, you give testosterone. And again, you're just aiming for the same serum level as a cisgender man. That's pretty much it. It gets slightly more complicated with feminization because you also need to suppress someone's testosterone. So sometimes we add in an androgen blocker. So typically something like finasteride or dutasteride if we're giving an oral, or a full block giving IM decapeptyl. That's kind of the medicine bit over. I just thought you might be interested to know it's really not that hard. So why is there a need for a clinic like Bridge? And to kind of illustrate some of the issues surrounding gender affirming care in this country, I've got a couple of semi-fictional case studies that I wanted to talk you through. So the first one is that of Ray, who is a 31-year-old trans masculine person. So they were assigned female at birth and they used they, them pronouns. So Ray was originally from Norfolk. They first sought help regarding their gender from their local GP, who lacked understanding, was quite dismissive of them. They then tried another GP, but were sadly transphobically insulted by another patient in the waiting room, so they didn't return. A couple of years later, they moved to London, and their GP there was much more helpful and referred them to the NHS Gender Identity Clinic. Unfortunately, the waiting time was over 5 years until their first appointment. This disappointment resulted in a downward mental health spiral. And during this time, Ray presented multiple times to their GP and was offered all sorts of things, including antidepressants, psychiatry referrals, ADHD assessments, talking therapies, but no one would provide a prescription for testosterone that was needed to treat their dysphoria. During this difficult period, Ray wasn't able to work. They were reliant on universal credit, and they had to move back to their parents in Norfolk, where they lacked friends and community. They started smoking cannabis and drinking heavily. So I think that brings up quite a few points. So, we've got the sort of urban rural divide, and finding a sympathetic GP. We've got transphobia in the community from other patients, long waiting lists, the effect that has on your mental health, the amount these patients present to their GP and use services as well when we're not giving them what they need. Um, so yes, next case study. So slightly different. This is Danny, who is a 28-year-old trans woman. So she was assigned male at birth and uses she, her pronouns. So Danny luckily has a supportive GP and she's already on the waiting list for the gender identity clinic. However, given the long waiting times, she realised that the only realistic way to access hormones was to go private. Now, Danny is a trans woman who hasn't accessed any hormones or gender affirming care yet. So her presentation has created employment barriers, and that means her income's quite small. So she can't afford private treatment, so she decides to DIY. And what do I mean by DIY? Well, she was buying vials of injectable estrogen. She was buying it injectable because she found it was cheaper than oral, and she was buying needles as well from unregulated online pharmacies. When she ran out, she would sort of borrow things off her friends, and that means that the preparation and dose of what she was taking was changing frequently. She was doing this with knowledge that she was mainly kind of getting word of mouth from friends, online forums, lots of Reddit forums, and social media. She did go to her GP and ask for some hormone level bloods to be done, but the GP refused because it wasn't in their remit. Their GP did, however, signpost to Clinic Q. So Clinic Q is an organisation that I'll probably mention again in this talk. They're based at Camberwell Sexual Health Clinic, King's College Hospital in Camberwell. And they're a trans-led organisation that provides support for trans people who are self-medicating. So they help give injections safely and offer guidance on hormone levels and how to adjust dosage. So she had some bloods done and her estrogen level was 1,200. If you're unfamiliar with that level, that's really high. The clinician at Clinic Q was concerned and advised her to adjust the dosage. And they were particularly concerned because Danny smokes 10 a day, has a BMI of 35, and has never had a blood pressure check. And again, if that's meaningless to you, what we're worried about there is the risk of VTE, so blood clots, which, if you've got high estrogen level and you've got other risk factors like that for blood clots is a concern. However, Danny refused to change what she was taking because there was no alternative she could access. So yeah, I think this case study really brings to light the real risk of harmful self-medication. If you don't provide something, people are still going to do it. They're just going to do it unsafely and unsupervised. And that means there's a real missed opportunity to look after people who have modifiable risk factors. So the other thing that's really important to understand is the kind of the status quo of gender affirming care in the UK. So if you're trans, the first thing you have to do, which is no small feat, is come to terms with your identity, come out, and then seek help. And that is probably going to be from your GP. Um, if you're lucky, you'll be referred to one of 7 gender identity clinics in the UK. So for us in London, that's the Tavistock in North London. Unfortunately, the wait time for a first appointment is well over 7 years. Now, this slide's quite old. It's more than that now, and it's constantly climbing. When you do get seen, eventually, you'll have at least 2, possibly more assessments by a gender identity specialist or a psychiatrist. And the goal is to get a diagnosis of gender dysphoria. So it's quite medicalized. And then you'll then be passed on to an endocrinologist, and that could be another year, who will give the okay for hormone therapy. Now, gender identity clinics have never prescribed. What they do is they send a generic shared care protocol out to their GP, and then their GP will hopefully agree to prescribe. So this has become more and more of an issue recently with GPs refusing to accept share care prescribing. And there's lots of reasons for that, including the sort of, pushback on GP workload, which I really understand. Unfortunately, that has a really negative impact on our trans patients. And it's worth pointing out as well that this is all for adult services. There is currently no adequate service for trans youth at all since GIDS, which was the sort of youth equivalent of the gender identity clinics, was shut down a couple of years ago. So the current provision of care for trans people is broken and not fit for purpose. We've got this really overly medicalized model of care requiring psychiatric assessment to prove your trans identity. You could argue that do you need a psychiatrist to tell you that you're trans? You probably just know. After that, you've got more than a 7-year wait for your first appointment at Tavistock, another year until you get hormones. So realistically, for many people, the only way to access gender affirming hormone therapy is via the unregulated private sector for those that can afford it, or DIYing. And unsurprisingly, so this was an important bit of work. It's quite old now, but it was for the Trans Live survey. Actually, there's a new Trans Live survey about to launch next week, I think, which I'm looking forward to seeing and updating these slides. But unsurprisingly, the majority of trans people don't think that NHS care is adequate. But it's not all just about gender affirming care. Trans people still need routine care. So they still need to see their GP. They still need to go to hospital appointments for a variety of chronic illnesses, etc. And this same survey found a lot of shocking things too. So lots of people reported that their GP had refused to provide care on account of their trans status. Lots of respondents said that their GP didn't have a good understanding of their needs as a trans person. And when accessing general healthcare services, over 2/3 of patients reported being impacted by transphobia. But I think this fourth bullet point down is the one that really gets me. So, and this is quite in keeping with the data we've got from Bridge Clinic as well. So about 2/3 of patients reported avoiding going to the doctor when they're unwell. That's shocking. That means people are so worried about getting discriminated against that they just don't present, which means that we're missing huge amounts of physical and mental health opportunities for them. And unsurprisingly, it's well documented that trans people have poorer health outcomes across the board, whether that is more likely to have a disability, multiple comorbidities, long-term illnesses, mental illness, substance abuse, smoking, etc. You name it. They're overrepresented. I'm sure it's no surprise to you as well that if you're waiting that long to get the care that you want, you're going to suffer a huge amount of mental distress. And as well as that, the sort of political and social climate is ever more hostile towards trans people. And again, this study is quite old, but it's such a poignant statistic. So it surveyed trans people in the UK, and it found that 84% of trans people in the UK have thought about suicide, and 48% have attempted suicide. So just let that sit with you for a second. That's the level of mental distress that people are experiencing while they're waiting for care that's being denied. And I guess my final point in why I think Bridge Clinic should exist is that I genuinely believe that GPs and primary care clinicians are the best. Sorry, I'm not sure how is everyone here wanting to be GP? You're not at that stage yet, are you? Well, you should be, because GPs are the best. And the reason that I think GPs are the best is that we are really, really good at providing access, especially to marginalized communities. We're really good at taking a holistic approach and seeing the whole patient, whether that is their looking at their physical health as well as their gender. Um, we're really good at kind of like coming up with a shared management plan with our patients, when, the sort of the guidance and the evidence is a little bit grey. And we're really good at addressing modifiable risk factors and keeping people as healthy as possible for as long as possible. Um, and it's really important to say that any GP can do what we do at the Bridge. We're not specialists. We're GPs who've taken an interest and upskilled. So let me tell you about Bridge Clinic itself. So, um, Bridge Clinic, we're a GP. Think of it like a GP clinic, but we're a hub clinic. So that means we accept referrals from all the GPs in our area. So we started off in South Southwark, which is a federation um, of GP practices, and we take referrals from all of them. We've been open for over 3 years now and seen well over 200 patients. Stop counting, to be honest. And we've got a new clinic now in Lambeth, so we're now providing care in 2 boroughs. We're funded through the ICB. We got our funding originally through Health Inequalities funding, and South Southwark we now have core funding, which probably doesn't mean too much to everyone, but don't worry too much about that. And we basically we've got two main goals. So the first is to be able to provide routine primary care in a trans affirming environment. So that's, anyone that feels unsafe or unsupported to go to their regular GP to have a smear test, to have diabetes care, you name it, we'll do it. But the bigger part of what we do is we provide gender affirming care. And in particular, we will start and monitor gender affirming hormone therapy. So in each clinic, we've got 2 GPs, a nurse, a healthcare assistant, and a greeter. And that greeter is trans themselves. And it's really important that the patient, the first person they see and talk to when they come into the clinic is trans themselves. All our referrals are managed by our nurse via email. The way we structure it is that we've got a monthly face-to-face clinic for each site. Southwark has a telephone clinic for routine follow-ups, and I hope we'll get one soon at Lambeth. And another really important aspect to the clinic is that we have really close ties with local services and the community. So I mentioned Clinic Q before, but other important organisations that we've kind of been friends with and done things in conjunction with since the beginning include Spectra, Lambeth Links, there's some other ones like Metro. So yeah, we're sort of closely tied in with the trans community. So how we work, we're not a commissioned gender identity clinic, so we're not a replacement for the Tavistock, and we're not kind of funded or commissioned like a gender identity clinic. So we refer everyone to the Tavistock if they're not already on the waiting list when we see them. That has pros and cons. It means, one of the cons is that we don't have any access to refer people on for gender affirming surgeries or other therapies like hair removal and voice training. And we don't diagnose people with gender dysphoria. So a lot of debate on whether that is a good or a bad thing. I still haven't made up my mind, but our view is that we're not really there to kind of decide whether someone is trans. It's more to support them through informed consent, whether or not they want to start hormones. So informed consent is all about making sure someone really knows what hormones will do, whether that's like the permanent changes versus the reversible changes, the risks, the monitoring that's required, yeah, making sure they and the effect on their fertility, for instance. Those are the really important things. And we also have a harm reduction model. So by harm reduction, that's kind of two main ways I think of it. One is that by providing hormones, we're helping people alleviate this huge mental distress that they are developing while they're waiting for care. But we're also reducing harm by stopping people turning to unsafe self-medication practices. So when we prescribe, we follow the Tavistock and Welsh guidelines. So we're really, really like strict about only prescribing within these guidelines. You won't get anything outside of the guidelines. So for instance, a lot of people will be on progesterone. We won't prescribe that, not because I think it's particularly unsafe, but just there isn't evidence to support it working. And yeah, because it's not in the guidelines, we don't want to do anything that sort of we could be accused of doing something dodgy. And another good example is lots of people are on spironolactone, which is a good androgen blocker, but they're a much safer alternative. So we tend not to carry that on for people. And we're GPs, so we will see anyone of any age, but we'll only prescribe gender affirming care to over 18s. As I said before, we're generalists, not specialists, and I think that is a really, really positive thing. We work directly on EMIS, which is the GP medical record, and we've got full access to the GP record. You'll probably realise from your work in hospitals by now that a lot of the time people have no idea what's been going on in primary care, and that's certainly the case when you go to a very sort of specialist centre like the gender identity clinic. They're not going to have access to anything. We also, and that means we can provide really holistic GP care every time we see someone. We write directly into the GP record, and that means that our colleagues can see what we've done. And it also means that we're sort of constantly exposing our colleagues to what we do and the prescription of hormones. So it becomes less and less scary to everyone. We issue our own prescriptions, so we don't ask GPs to take on a shared care prescribing thing. So we're not getting them to, we're not increasing their work, we're taking work away from them. The only thing that we have to do is we have to ask GP practices to generate blood forms and referrals on our behalf. And that's partly just because of the way that the IT works, but also it's to do with safety. So we're only a monthly clinic. And although most of our blood tests are not, it doesn't matter if you don't look at them straight away, you've always got to structure a clinic with safety in mind. So if someone suddenly had a really low hemoglobin for whatever reason, you need someone reviewing that on a day-to-day basis, and we can't provide that, so we ask GPs to do that. And importantly, we discuss all of our patients as a team at the end of every clinic. So it's not just one MDT meeting, we discuss all our patients together at the end of every clinic that we see them. So I can talk you through a typical patient journey, and this is for a very straightforward person who's seeking gender affirming hormones. So in order to access us, they've got to be registered with their local GP, so either in South Southwark or Lambeth, and they can either refer themselves or they can be referred by a GP or a health professional. Our nurse manages all the emails and will put them into the clinic. Then when they arrive at the clinic, the first person they meet will be our greeter, who, like I said, is trans themselves, and they can kind of settle their nerves, coordinate the clinic and explain the process. We've got really great trans greeters, actually. Our one in Lambeth has been really trying to set up a sort of like neurodivergent friendly room in the waiting room, because a lot of our patients have, might need to sit in a slightly quieter room, for instance. And then the first appointment you're going to have is going to be with a GP. It's usually half an hour and face to face. We're unlikely to prescribe unless unless it's particularly indicated. It's more of an information gathering appointment. And what we'll do is we'll take a thorough history, exploring someone's gender dysphoria, their aims for the future, and any obvious contraindications for gender affirming hormones. We'll obviously look at their past physical and mental health history, any diagnosed or undiagnosed neurodiversity, medications, allergies, and look at their social setup too. Everyone gets a comprehensive physical health check, which includes baseline bloods. We can obviously offer any lifestyle coaching for things that come up, whether they've got like high blood pressure or pre-diabetes. We talk about fertility with them because gender affirming hormones will, the best way to think about it is that it makes you infertile. That's a bit simplistic, but you have to think about your fertility. And also contraception needs, because a lot of trans men will still need contraception. We'll also refer them to the gender identity clinic if they haven't been referred already. At this point, if needed, we can refer them for gamete preservation. So if you do want to preserve your fertility, you can get your sperm or eggs frozen. And there is a service where we can have that done for free on the NHS. It's really great at Guy's and St Thomas's. We can offer appropriate screening, like if someone's late for their smear test, we can do that. And we can signpost to local services like Clinic Q and Spectra who offer trans peer-to-peer psychotherapy and mentoring that might be really relevant to someone. Providing everything is all right, we'll bring them back for a second GP appointment and take them through a really thorough informed consent process. So I kind of mentioned before, but we talk about what changes are permanent, what are reversible, talk about fertility a lot, especially with our younger patients, and any risks involved. And then if we're happy, we will start a prescription. And over the coming months, we'll titrate someone's estrogen or testosterone to stable levels. And we may add in an androgen blocker like finasteride or decapeptyl if we need to. After this, we follow everyone up with blood tests and physical health checks. And if they're stable, we check at 6 months and then just annually after that. When patients are quite stable and uncomplicated, we might follow them up in our telephone clinic or with our nurse just to kind of preserve our capacity for seeing new patients. But we do try and maintain continuity with the same clinician wherever possible, especially when patients are more complex for whatever reason. And just reiterating that we discuss everyone as an MDT after every clinic. And then I've just got a couple of case studies showing how I think our approach is particularly helpful. So the first one is that of a 60-year-old trans woman that we saw. So she was DIYing oral estrogen, spironolactone and progesterone. So oral estrogen, remember what I was saying about blood clot risk? So she had had multiple PEs, blood clots in the lungs, over the last 18 months, despite being on blood thinners, on a DOAC. She was seen by haematology and her own GP, and for some reason her gender affirming hormones had not been addressed. Don't know, maybe she hadn't disclosed them because she didn't want people to know or to take her off them. So we saw her and we switched her over to transdermal estrogen. So if you give estrogen through the skin rather than orally, you take away that risk of blood clots. And we got them to stop spironolactone and progesterone. We also helped them change their gender marker on the NHS record without erasing their medical history. So don't want to labour this point for you because you don't need to get involved with these boring bureaucratic intricacies of the NHS. But if you want to change your gender on your GP record, it's quite an arduous process. And what would happen is that they'd actually create a new record for you and kind of delete all your old record, which makes life really difficult for everyone. Very recently, this process has changed and you can now change your gender without. Lots of people are unaware of this. The next case study is a sort of more uncommon type of patient we see that's more for the sort of physical care. So they're a 48-year-old, assigned female at birth, non-binary person, and they were quite a tricky character. They hadn't been to mainstream services for 20 years. had sort of relationships had broken down with loads and loads of GPs in the past. They've very poor trust in healthcare providers. But an advocate from Spectra, one of those organisations that I mentioned, had managed to re-engage them and get them seen by us. So we saw them and managed to get them to a dentist, get their earwax removed so that they could hear properly. And really importantly, gave them some tranexamic acid, which reduces heavy periods, which they'd found really transformative, and got them started on some blood pressure medication. Haven't quite convinced them to have a smear test yet, but they are closer than they've ever been before, which I think is a huge win. So, how are we doing for time? Oh gosh, okay. So I guess that's the bit at the end of the stuff about the bridge. So now I'm going to tell you a bit about how it happened, and in doing so, I'm going to tell you about my own career path. I'm a bit worried that this is where I'm going to start rambling uncontrollably and we'll all be here for hours. So I will try and speed through things, but I've been told that this is, of particular interest to you all. So I guess I call myself a GP with extended roles in women's health and trans health, but it all kind of started for me in sexual health, I guess. And it goes right back to university. I was involved in Sexpression. I hope that's an organisation still going, and some of you might be involved. I did a BSc in international health, and my dissertation at the time was about transgender people in Pakistan, and long before I had any idea that I'd be doing this kind of work. Um, and then I had a few sort of lost years where I loved my obs and gynae job. I applied for obs and gynae very naively without doing any work for it, didn't get a job, and very quickly realized that I did not want to be up at 7 a.m. doing ward rounds for the rest of my life. So I then spent a few years traveling. I did a psychiatry job, didn't like that. I did a diploma of tropical medicine in East Africa and thought I was going to go and work in sub-Saharan Africa for a bit. But at some point in this process, I realized I was really into sexual health and discovered this program called Community Sexual and Reproductive Health, which was quite a new program at the time. It was super competitive because there were no jobs in the country. So I applied, didn't get a job, but I did get this gum research fellow job at the Royal London Hospital in Whitechapel, which was amazing. I absolutely loved it. And I was working on a research trial that got high risk gay and bisexual men in East London onto PrEP, because at the time PrEP wasn't available in the NHS. You needed to be on a trial to get it. And the thing that's really nice about research is that your time's quite protected. And if my research clinics weren't booked out for whatever reason, I had lots of free time. And I could have just bunked off and gone home early, but I was a massive kilo. And I went and spent loads of time with the consultants there. And I did my training in DFSRH, which is the contraception qualification you need. I learned how to fit coils and implants. So I came out of that with really amazing skills, and I'm so glad I did that at the time, because in hindsight, it's really expensive and hard to get those skills elsewhere. I then got very close to getting a CSRH job. I came fifth in the country, but there were only 4 jobs, so I didn't get a job, but I did get a GP job. And I thought to myself at the time, I've really got to get back into training because I've been out for 3 years. I took the job, thought if I don't like it, I'll reapply. Fortunately, I loved it, and the rest is history. So I I specifically requested obs and gynae and gum jobs, and I got them. So I said, look, I want to be a GP with a special interest. So um, before I'd even started the program. So when they were allocating jobs, they gave me those ones. So that's my first top tip. Ask for what you want. And again, I was a keynote. I used my sometimes you get these CPD sessions where you can go to clinics and get more experience. And to be honest, most of my friends just took the afternoon off. I would swap my clinics around so that I could go and sit in menopause clinic. Um, and yeah, did that. And then my gum job was great as well because I basically told them my experience, and they sort of ripped my rota up and said you don't do the gum SHO job, we'll create a new rota for you. So I was then on the LARC rota, doing coils and implants, doing the PrEP clinics, doing the HIV emergency clinics, and that was great. So yeah, loads and loads of experience from that. And then, to be honest, I took a bit of a pause because in my ST2 and 3, I just focused on being a GP and getting through GP training because that's quite enough. You don't need to always be pushing your special interest. Um, after I oh God, I'm worried about time. I'll try and speed up. So after I finished GP training, I was then I basically emailed every sexual health clinic in London trying to get a job because I wanted to keep working as a GP, but I wanted someone to give me a job like 1 or 2 days in sexual health so that I can develop that side of things. It was almost impossible. No one wants to give you a day a week job because they basically want full-time people because there's quite a lot of like governance processes to employing someone. So it's a really hard sell to say 1 day a week, even if you are like quite well trained and they don't need to give you lots of training. Um, so yeah, got lots of no's for a long time, which was really disappointing. And I thought, oh God, maybe I can't be a GP with a special interest. And especially as a man as well, like a lot of female patients won't present to me, they'll present to my colleagues, even though they don't have the same interests as me. But then two really experienced clinicians retired at Camberwell Sexual Health Clinic, and they knew me there, so they basically called me up and offered me a job. Um, so I got really good at doing coils and implants, doing that. And after a while, I thought, right, what's my next skill? What do I next want to learn? And I thought about lots of different things like, should I learn to scan? Should I go and learn to do abortions? But I thought, you know what? General practice, primary care, what is the real remit? And I thought menopause makes the most sense. So again, really difficult to get a menopause trainer. It's so in demand. But fortunately, I managed to contact my one of the GPs at one of my SD3 practice, I'm going to speed up a bit now. Who basically she took me on to trainee, which involved me doing like a free clinic every other week for a year. So it's quite an undertaking. But then this did transpire into them offering me a job where I was doing like half menopause and half LARC. And that led into developing the Women and Girls Health Hub, um, which I knew all about because throughout this time I'd been like going to conferences, being a keynote, knowing that there was this big political shift towards Women Health Hub. And I guess I was kind of training myself, knowing that at some point these health hubs are going to exist and they're going to want GPs with a special interest. So what am I going to need to be ready for that? Um, and I'm still, still developing my skills. So, my big goal at the moment is to try and get better at fitting pessaries. But there's all sorts of things that I could learn. So it doesn't stop. It's worth saying that, I kind of balanced what I was doing with general practice with the special interest. So I started off as a salary GP and I was doing like 6 sessions, that's 3 full days, versus like 1 session of special interest stuff. I then left that job and started locuming, and that allowed me to be a lot more flexible with doing the sort of free menopause work, get paid a bit more as well, so it can kind of supplement you doing work for free. And then I went back into salaried work because, to be honest, my work plans were getting so complicated. It was actually really difficult to be constantly changing the days that I was working, and I was starting to like go into work on days off and not turn up when I was supposed to be there because it was so confusing. And I've more recently reduced from 6 sessions of GP to 4 sessions of GP just because of my other things taking up too much time. So I realized, talking a lot about my special interest developing, it's mostly about sort of sexual and reproductive health, isn't it? And I did want to kind of talk about how we developed Bridge Clinic and this interest in trans health. Um, but I think it is all relevant because if you'll excuse the terrible pun, I did have lots of transferable skills. Um, because I was already doing lots of stuff with contraception and menopause. So I guess I was quite like, I knew my way around a hormone. It's just that this was a new way of applying that knowledge. Um, but the beginning of the Bridge Clinic really started with my first GP job where I met a nurse called Flora. And we became best mates, still are really good friends. We just went on holiday to Thailand together. And they were really interested in trans health from the get-go. And I was then working at Camberwell Sexual Health Clinic, where Clinic Q was based. So I introduced Flora to that team, and in particular Michelle Ross, who's the head of Clinic Q, and Michael Brady, who's one of the gun consultants at King's, and also is the lead for Clinic Q, and also became at the time the NHS England advisor for LGBTQ health. So pretty big dogs, but we kind of formed this little like SWAT team of people who had this shared vision of a clinic that actually prescribed. Because Clinic Q is amazing, and they do so much incredible work to support people who are self-medicating, but they don't have any remit to prescribe. The best they can do is write a letter to GPs kind of begging them to start a bridging prescription. So we thought, wouldn't it be better if we could actually just do this? Then there was a bit of funding for, bear in mind, Flora and I were like really junior in our career at this point. Flora had been a practice nurse for like just for like a year. I had just started as a GP. So, we didn't know what we were doing. There was a bit of funding to put on this like primary care education event, which we ran. And this is where we met our colleague Becky. Now, Becky was, well, and still is, she's a senior GP partner in Southwark, and she was very high up like politically in Southwark. So she was like one of the clinical leads or medical directors or something of the South Southwark Federation. So she knows what she's doing in terms of like funding, commissioning, and she knows who to get involved. And she came along to our education event and basically went like, "Oh my God, this is awful. I'm going to call Nigel." And she called Nigel, who was basically the man who has all the money in Southwark, and she put together a business case for us and got some funding agreed for a short pilot of Bridget Southwark. It was only a short pilot, but we kind of felt that if we could just get started, then no one was going to shut us down. And the rest is history. So yeah, like I said before, we've been open for over 3 years, and we now have a new clinic in Lambeth. I guess the development of the Lambeth clinic's been really interesting for me because Becky has stayed in Southwark and has not come with us to set up the Lambeth clinic, which meant that I had to be very brave and sort of become the clinical lead without her support, which has been a huge jump up in learning for me. Um, and yeah, but things are going really well. So I hope that has kind of demystified a little bit how you kind of go from qualifying as a GP to setting up services, setting up and developing skills that mean you can have a really interesting career in your own image. Because the thing about being a GP with a special interest is that it doesn't really exist. You just kind of have to you have to envision it and then make it happen. So I'd say for all of you, just have a bit of a vision of what you want, and that vision can change. The vision might be I want to work part time or I don't want to be too stressed. That's fine. But think what you want your life and your career to look like a little bit, and then develop your skills accordingly. Um, you can't do it all at once. You have to think of this as like, think of long term. So maybe you're just thinking of what am I going to do this year? What's the first step in this? It might be this year I'm going to do contraception. This year I'm going to try and learn to fit coils, whatever. And I think you probably are going to need to do a bit of unpaid work at some point because often developing skills means you have to be supernumerary. And unfortunately, there isn't the money to fund everyone to go and just learn things forever. And I guess that's why people get training programs. But it's fun if you think about the value of unpaid work. Is it training you, or are you just providing some kind of boring service provision that doesn't get you anywhere? I think that's the way to think of the value. Like my menopause clinic, so much value I've got from it, and it's now led me to a point where I'm paid a good rate for what I do. Um, Networking is so important. Like, talk to everyone, and like you just sort of slowly build up a team. Like that makes it sound formal. When I say build a team, I basically mean make friends with people who kind of have the same values and want the same sort of things as you. Um, but it's also really important to just generally show up and be active. Like, so, you know, go to conferences, go to meetings, be vocal in your training groups. Um, and that involves also sort of like selling yourself. So when I say that, what I mean is like, so I'm a GP with a special interest in women's health and trans health. That's not a thing. I just started saying that at some point. And after a while, it kind of becomes true. But definitely at the beginning, I was kind of faking it a little bit. But what it means is that everyone always knows that that's my thing. And so then when opportunities appeared, they think, who's like at the top of my head to think of for this? It's that. So you've got to make sure that everyone knows what you want to do, because 9 times out of 10, there'll be no funding to do what you want at the very moment. But then 6 months later, it'll suddenly appear and they'll probably have like a week to spend that money and they'll desperately be wanting to spend it on you. So yeah, be vocal.
Max,
Oh,
do you mind
yes.
if
No,
I
I'm done.
stop you there? Oh, perfect.
I'm
Okay, just
done. I
because I can
just
see the
managed.
questions are coming in,
Yeah,
and yeah, your last point really led me to a good point in terms of yeah, because Max is so like is so vocal about like his special interest in this and things. When we were talking about this with our students, as in the subject of this talk, I was like, aha, Max, I know the person. So
totally.
definitely, yeah, sell yourself out there. Max, so super interesting, and also as well personally, I can say like, yeah, the Bridge Clinic has been super helpful for. I've contacted them a few times about various patients, and they've been really responsive and things. So if anyone works in Lambeth, or South Southwark, please, yeah, use them. I'm going to start quickly, if that's okay, Max. So going to the question. So Macri was asking a point about, I guess, risk calculators. And so things like Chad's VASC, Q-risk, and whether they don't include an option for trans individuals. Is there any guidance regarding how to classify trans individuals in these calculators? And do you think having this as an option or guidance could somewhat medicalize or be a bit more inclusive, I suppose, for trans patients in the community?
Yeah, I mean, there's loads of examples of this, how trans people just aren't included in these things. And to be honest, there's just no evidence. No one knows what to do. The general thinking is to use the most high risk things. So, typically if you're doing like a Q risk or a transfast thing, it's more high risk to be male generally. So actually, I don't know if that's true with transfast, but Q risk, it's more high risk to be male. So if someone so we would use male in both contexts, both as like someone who was assigned male at birth, but also someone who was taking masculinizing hormones, because then you're kind of overestimating your risk. So
Yeah.
that's a practical answer, but yeah, the answer is we just don't know.
A good point there to be safer. Margot, so she's one of our colleagues at City St George's, says, great to hear about your wonderful work. I worked with George's healthcare students to develop a trans MOOC, which has since been taken down. I wondered what training you thought all healthcare students should have to be trans effective and friendly.
Oh, I don't know what a MOOC is, but
A MOOC is like a massive online. I forgot what the other O is, but it's like an online community like training module basically. Sorry, Judith, feel free to step in. I highlighted my ignorance of, I can't remember what it stands for now, but yeah, as I said, it's been taken down. So is there anything that you think could be or should be included in our healthcare courses?
Yeah, I mean, it's such a shame it got taken down. I'd really sort of do whatever you can to push for that to get back on, especially if the work's already been done and it's there. Um, I mean, I think traditionally it's not been on the curriculum at all. Um, and I mean, oh gosh, what should specifically be included? Um, I guess you'd know more about medical students' needs than me. I mean, I guess there's this sort of general like trans awareness stuff about kind of, what being trans means, how to be nice using the right pronouns and stuff. And that's really important because, most people won't be most sort of clinicians won't be directly involved with gender affirming care, but they will certainly meet trans patients, and they will be involved in planning services that will be used by trans patients. And it's just important that they have knowledge of their existence and what their needs are. But yeah, it would also be really great to kind of have a bit of the medical side of things in too.
Yeah. Yeah, I agree. I think it's those, and this kind of leads me quite nice into the next question, maybe less so for medical students, but you know, what we talked about this, you've kind of, I guess, developed the bridge in Lambeth, but obviously these don't exist. You know, there is how there's an equity, I suppose, across, you know, the NHS, and some places won't have that. This is, sorry, I can't see the first name, but one of our questions says, are you finding there is interest from other boroughs in providing this type of clinic to provide equal access in London, or even if you've heard of it further afield, for trans and non-binary patients who want to receive primary care in this sort of a gender affirming setting?
Oh yeah, absolutely. I mean, so we set things up in South Southwark, but Lambeth kind of came to us and helped to set Lambeth up. So the story of starting, I probably should have talked about this in more detail, but how we started South Southwark was this really kind of like informal, fluky, under the radar way. We have no idea how we got commissioned, but by the time the South Southwark clinic was up and running, like it was really successful, and we were sort of like slightly famous within what we did. And so Lambeth wanted a piece, and they came to us, and they, you know, they had sort of manager people who would like write the business case for us and do those boring bits that I don't know how to do. So it's a totally different story. And you know, there's loads of examples of really good practice in other parts of the world, and like I do think Bridge is a particularly good model, but it's not the only way that you can do this. There are a few GPs who kind of take on lots of extra patients into their GP list, but I think that's a bit, I think that's quite unfair on them. And it's a bit too postcode lottery as well. But yeah, I get emails all the time of people wanting to come and sit in, or asking if they can refer their out of area patient, and sadly the answer is no to the referral. But yeah, if anyone, you know, is in a position to, or knows people who want to set up bridge-like clinics in their area, we're so happy to support and have you shadow and give you advice and show you our like business cases and stuff, because there's actually quite a lot of political support for what we do now. So there was a big report called the Levy Report, which is like the adult version of the CAS review, and actually it was quite supportive in the idea of this sort of role for a GP with a special interest and GP hub clinics, that can kind of meet this massive health gap.
Just getting through a couple more as much as I can. So I'm sort of paraphrasing a little bit, but one of the questions was, how often do you find patients change their mind to decide not to start gender affirming hormones? Yeah, do you get, I guess that's quite an interesting, yeah, do you, in terms of the counselling aspect, yeah, how often do you see it, people changing their minds? Is that something you see very often, or?
Never really. We had one patient that I remember, and this is just from my own head rather than like, you know, a detailed audit or anything, but yeah, we had one patient who I think we gave a prescription of testosterone to, and they came back and said, actually, I've had another thought and I don't think it's for me right now, but they were still really happy with the care that they'd received, and the opportunity to get it, because we're not promoting being trans or taking hormones. This is people who are desperately seeking this, who come to us wanting it. What we do see a little bit more commonly is people who are sort of lost to follow up. So for whatever reason, they go, you know, they move somewhere, or they go through a very difficult mental health time and, you know, kind of stop turning up, which means they have a gap in their transition, but that's not because they don't want it.
I've got a couple more very quick. Again, paraphrasing it. It sounds like one of our attendees, they know someone who was trans Mask and had lived as a man for a while, and they were talking a little bit about fertility counselling. Unfortunately, this person became pregnant, and obviously, which is quite distressing. Is there much guidance for GPs on fertility, or is there any like resources you can signpost to for fertility advice for trans people? I appreciate, for me working in Lambeth, I'll just be like Bridge Clinic, but for people who don't have access to that, is there anything else? Is it on the Tavistock or the Welsh guidelines? I can't remember.
So for contraceptive advice, which I think is more what they're getting at,
this is talking about contraception. Yeah, exactly.
Yeah,
but also fertility would be interesting if you know of any.
Yeah. So the College of Sexual and Reproductive Health has a guideline on this, and it's really helpful. But I mean, basically, the important thing is that testosterone, even if it stops your periods, isn't contraceptive. And a lot of trans mass people will still have a vagina, and they will still have penis and vagina sex. That means that they can get pregnant. So they may well need contraception. The only thing you can't give them is estrogen containing things. But everything else, all the progestogen methods are fine, and they can actually help induce amenorrhea. So they can be helpful in their own right. So yeah, really important to think about. And testosterone is really toxic to an unborn baby as well. So you don't want to get pregnant while on testosterone. In terms of fertility, oh God, I couldn't point you to an exact like guideline to look at, but it's important to consider your fertility before taking gender affirming hormones, because the longer you're on gender affirming hormones, the more likely it's going to be too late if you do change your mind and you want to have biological children of your own. For those of us in London, the Guy's and St Thomas's Assisted Conception Unit takes referrals for trans patients for gamete preservation before they start gender affirming hormones. So you can just contact them through the email for the fertility clinic there. They're really good. They see people really quickly, because it's the same sort of pathway as people accessing gamete preservation before they go on chemotherapy. So they're used to really quick turnaround. So it doesn't delay people going on hormones. And they can give you, they've sent me guidelines before, actually. Yeah.
Nice. I'm going to, Judith actually has a lovely couple of questions as well, but I'm going to have to end it there for a second, if that's okay. So thank you so much, Max. Just before I let you all go, there's a QR code here if anyone would like to provide some feedback, and also you can access a certificate of attendance if you'd like that for joining this evening. So that takes us to the end of our primary care seminar series of 2025-26. So thank you so much if you've joined us for today, but also any previous ones. And if you would obviously like to catch up on anything that you've missed, you are welcome to head to our website, and the recordings are all up there, including of today's. So thank you so much, Max, for your incredible talk today. It's been super interesting hearing about what's happening locally, and hopefully about what will happen down the line as well. I will leave it all there. So thank you everyone else for joining, and have a wonderful evening. It should